So welcome everybody. We are here at the 𝗪𝗶 Consortium kickoff meeting in Amsterdam. And we are here to get all the work packages together and try to see which of the part of the consortium are taking over which of the topics. And these short videos and interviews are meant to introduce the separate work packages. And I'm here with the biostatistician institution members of the UKE in Hamburg. And thanks for being here. Thanks for participating on this short interview. And maybe we start with a short introduction of yourself.
My name is Antonia Zapf. I'm the leader of the Institute of Medical Biometry and Epidemiology and also leader of the work package 4.
So my name is Fabian. I'm a clinician, but also a biostatistician working at the Institute, co-leading the work package 4 together with Antonia and Susanne.
I'm the second co-leader of the work package 4, Susanne Sehner, and I'm a biostatistician 2.
So we are here to discuss separate topics on AF burden, obviously. So the question regarding your view on the data set and on the entire topic, what do you think is the most exciting and most important thing that you will deal with within the next 48 months of this consortium project?
Yeah, I think the main aim of our work package is to quantify the effect of different AF burden levels on cardiovascular outcomes, like more specifically MACE outcomes. And from a traditional point of view, this was done by just dichotomously diagnosing AF at baseline. And nowadays we know and have the first evidence that it might be better to differentiate the effect of different AF burden levels on cardiovascular outcomes, which is what we're aiming for. And we will methodologically support this endeavor, and we're very excited to do so.
Very good. So from the perspective that you have now as biostatisticians on this field, where are we standing? I mean, what is the main topic where you think this leads us to the direction that AF burden is a better parameter than the dichotometer saying, is there AF or is there no AF?
I mean, obviously, this will be the need to use observational data or RCT data to just differentiate between just a dichotomous diagnosis of AF as compared to different levels and investigate the effect of these different levels on cardiovascular outcomes. And I think that is what we need to really guide treatment decisions in the future, whether we need a more differentiated approach to AF treatment when there's different levels of AF burden.
And when you look at the data that you are working with right now, I mean, I would think that this is very heterogeneous kind of data that you're facing now that you have to work with, because we have so many stakeholders and partners that are contributing data. And I can imagine that it's really some sort of mixture that it's difficult to deal with. So is this part of your project to try to homogenize these data and to see how to work with this? And what would the approach be to try to get a better picture on the data set that we are trying to acquire and to get together?
Yeah, so I think it's not possible to take all the data together and to answer one question. So we will have several sub-research questions in our project, and we will use different data for different research questions. So for example, for some sub-questions, we will use the data of the control groups of the randomized trials in further aims. We will use the insurance data. And so we really have to look which data can give us which answers.
Yeah, I think this is going to be one of the most important aspects. And is there anything else you would like to highlight, or what your hopes and visions are for this project?
For example, in the EAST study, the former study, we already saw as an association between AF burden and outcome. And I think that's really the first step. And our big aim is that at the end, we really know which AF burden is relevant for the patients and how can we influence and lead to an advantage for the patients by treatment. So which patient with which AF burden has to be treated in which way.
How do you envision to assess risk in this particular patient better than with the tools we're using today?
So I think at the end, hopefully there will be something like a risk score. So where the AF burden is one part, but not only, it's also other characteristics of the patient, so risk factors. And so that really at the end, you can recommend the individual patients the suitable treatment.
Thank you so much for the time spent here to answer these brief questions, and looking forward to work together with you on this project. Thank you.
Thank you.